Hello. Good evening to all our live viewers. My name is Randev and I will act as the host of today's webinar. Today's webinar will be focused on the topic of facing COVID until the vaccination, which is done by QuickMed Online Private Limited, partnering with the Interact Club of Isipatana College. So to talk on today's topic, we have Dr. Srimal Silva, a medical officer in the anti-leprosy campaign of Sri Lanka, as well as Dr. Krishan Hirimuthugoda, who is the regional epidemiologist of Gampaha. So to talk about on the structure of today's webinar, the first 30 minutes, the doctors will go into detail on today's topic. And the last 15 minutes of the webinar, we will accept questions from the audience, which can be sent to us through using the inbox of the respective Facebook page that you are watching live from. So to kickstart the webinar, I will hand over to Dr. Srimal, who will be starting off with this topic until Dr. Krishan enters the webinar. Dr. Srimal, over to you.
Thank you, Randev. Good evening, everyone. So, as Randev stated, we are prepared to speak on a few topics related to COVID and what the general public will find important during this phase until we go ahead with immunization for all. A few topics that we have prepared and we hope to cover up despite time constraints. There would be the stages of pandemics and how do strategies differ according to each stage, and what are the success stories of controlling COVID-19 at field level in Sri Lanka, followed by how factory pandemics were brought under control and what were the strategies used. So before we go into these topics, let's briefly talk about masks and respirators, and something which most people would be quite familiar with now, just to brief and brush up on it. So as you can see, masks and respirators are generally coverings for nose and mouth and are of protective value, especially in a pandemic such as this. So we can speak about masks being loose fitting, face masks including cloth masks and various other non-protective masks which don't have much of a filtration towards bacteria or viruses. Along with surgical masks, which does have a good protective value and is recommended during a pandemic such as this. Then after that, we look at respirators. You get various types of respirators, including particulate respirators, gas masks, etc. What matters to us right here during this pandemic is the particulate respirator only. So in that you get various types, different grades of respirators, and a popular type that we know about is the N95. As you can see, types of respirators here. Firstly, the surgical mask, which is commonly used, is a 3-ply mask with a hydrophilic inner layer and a hydrophobic outer layer, followed by the N95 respirator, which is more protective in value and includes a electrostatic layer which binds with particulates such as viruses. And then we get various other more advanced types of filters and respirators. The picture 3 here shows respirators which have a disposable filter. While the mask itself is reused, the filter is disposed of. And then furthermore, air-powered and flow-powered respirators, which are not generally for the general public. So basics in using masks. I hope that the photo is visible. Is it visible? So basics of using masks. most people would be quite familiar by now. First, wash hands,
Excuse me,
hold
doctor.
the ends of the mask. Yes.
Sorry, doctor. Doctor, could you just tap twice on the image because it's not visible to the public right now.
I see. Is it visible?
Still not yet, doctor. If you could just click twice on the image, it should come then on the file. The mask respirators.
Is it visible? Is it
Still not
visible
yet,
now?
doctor. If you could go to the, no, if you could take it to the gallery, doctor, there it should have opened onto the gallery or onto the, one of your photos on your tabs.
No, not yet. Is it visible now? Is it visible
No,
now?
doctor. No, doctor. I'll tell you what.
No.
If you could on your phone, doctor, you can carry out with your presentation. You can send an email to us and we'll do the share screening part. You carry on with your presentation, doctor.
Right. Okay. So when we look at N95 masks, what N95 stands for is a standard of quality. And as a respirator, what is important is to make sure that it seals properly to your face. So to check what is called a positive seal check and a negative seal check. That is, after fitting on the respirator, the N95 mask, we tighten the metal hole to the nose bridge, and we breathe out strongly into the mask to check if it has sealed properly. And then we breathe in strongly to check if there is any vacuum buildup, to make sure there is no leaking of air out. If there is no seal, then the effectiveness of the mask is greatly compromised. Okay. So that will bring to a close the discussion on masks and respirators. Now we will move on to the main topics that we have prepared for the evening. I would like to welcome Dr. Krishan Hirimuthugoda, the regional epidemiologist of Gampaha district, who is well versed in COVID-19 and its control. He has been working in the field level from the very start of the pandemic at the beginning of last year. He is a senior registrar in community medicine, and at the very beginning of the pandemic, he worked in the Kalutara district as the focal point for second stage of the pandemic. He was appointed to Gampaha district as a regional epidemiologist. So good evening, Dr. Krishan.
Good evening, Dr. Srimal.
So the topics that we discussed for today evening, what are the stages of pandemics and how do strategies differ according to stage? So if you would like to talk about
Yes, good evening to all. Today we are going to discuss about the different stages of the pandemic, as well as the strategies and the intervention that differ with the stage of the pandemic. So when one disease, infective disease, it is spreading around the world or global context and spreading around in our country context, we are naming it as a pandemic disease, right? We have faced many pandemics during last few decades, and we fought against those pandemics, and we won many pandemics by using the vaccination and with our controlling strategies. So anyhow, in the pandemic, we have 4 stages, basic stages, not only for the COVID-19, but for all other pandemics related to the infective diseases. We name it as a separate stages because we categorize into separate stages. So the status differ with the separate stages. So first stage of pandemic is the no cases reported stage. So at that stage, no cases were reported. As you remembered, at the early February, early January in 2020, our country was in that stage. No cases were reported at that time. And the second stage was sporadic cases. We experienced the sporadic cases of COVID-19, but it is not actually related to one particular cluster, right? It is not particular to one subcluster or cluster. It is sporadic cases. We can find the cases here and there, but it has some contact. It has some index case. It has source, index source, and it has some contact. So, but it is sporadically happening all around the country. So in that stage, we name it as stage 2. So our country during last year from February to almost that we experienced the naval Valisara cluster. Till then, till August, I remember, August or July, till July, we experienced in the stage 2 of pandemic in last year. So after that, we actually fell into stage 3. Stage 3 is a cluster of cases, right? The first stage is no cases reported. Second stage is sporadic cases reported. And third stage, a cluster of cases. So now, currently also, we are in the stage 4. Our country is experiencing the stage 4 of the pandemic. And it was experienced once in the last stage.
Stage 3.
Stage 3, yes. We experienced the same stage 3 in the last year with the cluster of cases in the naval base Valisara in last year. So the stage 4 was the stage that we experienced the community transmission. So that means we experienced the cases coming from the community, but exact cluster or exact channel, exact contacts cannot be identified. So in the community transmission stage, what we experience is we got the cases usually from the general practitioners and the OPD context, right? They are referring to the general practitioners, and general practitioners referred to hospital and get the PCR done, then the COVID-19 positive. So it is a one indication if we get the patient from the general practitioners and the OPD, the COVID-19 positive patient. So that means we are in the community transmission stage. But here, still we are
in stage 4.
Stage 4. That is stage 4, community transmission stage, right? Still in our country in stage 3, that means the cluster of cases. So we are still finding the COVID-19 positive patient among contacts only, right? There are some community cases, but always more than 85 to 90% of them were connected to or channel to one of the clusters that we have identified, named as Brandix cluster, as well as the Paleocoda fish market cluster. So so that is the basic stages of the pandemic, but I will explain the strategies, targets, yes, strategies, targets, and intervention that is differ with the separate stage, right? In the first stage, no cases reported. At that stage, but we are mainly focused and we are strengthening only for the surveillance, right? We are doing the surveillance. Surveillance means we are actively finding the cases, not passively. We are actively trying to find the cases. So for that surveillance purposes, we usually doing the surveillance at the port of entry, right? Port of entry, mainly the Katunayaka, the main our airport, as well as from the harbor. So, and we have to strengthen our international coastal borders as well. For as a surveillance purpose, we are actually informing. We informed our naval troops to protect our international coastal border because of a lot of smugglings and frauds are happening in the wrongdoings were happening in the international coastal border. So other than that, other than the port of entries, we strengthen our surveillance at the hospital context. Right, we ask our doctors who are working in the OPD, who are working in the medical clinics, and our general practitioners, if they have some sort of suspicious over a one patient who are having the symptoms related to COVID-19, that patient should be referred to hospital, or if that patient was diagnosed from the OPD context, that patient should be referred to PCR testing in the same hospital, or the hospital that have isolation facility. So we have identified the isolation facility hospital for each district, basically district general hospital. So we increase our surveillance system. So that is the basic but very important strategy intervention to be implemented at the time of stage 1, when no cases are reported. Right, so it applies not only for the country level, but it applies to the districts, it applies to villages, it applies to factories as well, especially for the BOI factories in Katunayaka and the other regions also. So in addition to that, if we experience in one particular district, or if we experience one particular factory is showing or is having 0 COVID-19 cases for last 14 days, that mean that particular factory or particular district is going for a direction of free COVID-19 for 14 days, mean that in the direction of stage 1 pandemic. So in the stage 1 pandemic, in that factory, the factory who experience more than 100 or 200 cases, but after 2 weeks time there are no cases, even with the PCR testing. So again, they go to stage 1. So they need to strengthen their surveillance strategies. Right. So that is the stage 1 main stage 1 strategies that we need to aim on. So stage 2, sporadic cases. When we experience sporadic cases in the country, or sporadic cases in the factories, or sporadic cases in the district, or sporadic cases in the villages, we have to do the contact tracing as well as the quarantine. That is the main strategies, main intervention that needs to be adhered. So if we abide to that sort of quarantining and contact tracing, we can control that one, right, in the stage 2. So what we did when I was the focal point to Kalutara district, so what we did in the Beruala, Kalutara and the other area of other main area that showed the sporadic cases, so we used the strategies of quarantining and contact tracing. So that is the main intervention for the stage 2. So stage 3, when we experience a cluster of cases, what we got during since October, Brandix cluster, and in the November, the Payalagura Fish Market cluster, we have to intensify the contact tracing and we have to intensify the quarantine, right? So the same principles, same theories, but we have to be intensified than what we used and what we implemented at the stage 2. So in the stage 3, contact tracing and intensified contact tracing and quarantine. So because the clusters, we are getting subclusters, sometimes in the cluster we are getting more than 1,000 cases over one night. It happened to us in Gampaha. In one night we experienced 680 cases from the Payalagura fish market, and we experienced 790 cases, COVID-19 cases in over one night in the Brandix factory. So it happens in some other garments, right? I can name 10 or 20 garments that we experience more than 100 cases over one night. So we have to intensify the contact tracing and intensify the quarantine. So in the stage 4, for the community transmission stage, we have to intensify the quarantining contact tracing. On top of the intensified quarantining and contact tracing, we have to use some other strategies, social strategies, like imposing curfew and imposing lockdowns. Those are the strategies that should be reserved, right? I must use the word reserved for the lockdowns for the community transmission stage. Lockdowns and curfew should be reserved for community transmission stage. When the country goes to community transmission, or the district goes to community transmission stage. What happens if we use this haphazardly, right? I will explain that also. We experience that there are some resistance from the communities, resistance from some premises, resistance from some housing schemes. People protested, right? Protested over these lockdowns, protested over these curfews, right? So I am actually against these curfews and lockdowns from the very beginning, from the March 2020. So I explained in every forums, in every official meetings, it is not necessary at this stage, but there are some instances that we need some curfew, that we need some restriction of social movements by imposing lockdowns. So, so the stage 4, we have to reserve lockdown and curfew for the stage 4. If we have used the lockdown curfew at the stage 1, no cases reported, or at the stage 2, what happened, right? I will explain with a small example, right? So then you can understand it. If you have a heart attack, are you going to are you going to indicate it for a bypass surgery? No, it depends on the stage of the heart attack, right? If the first stage, the small heart attack, it can be managed with the antiplatelets and oral drugs, right? If it is some bit stage 2 or stage 3 heart attack, we'll go for some injections, infusions, and sometimes for this what you call this angioplasty, angiograms, and angioplastics, right? Balloon angioplastics. So if those intervention, those therapeutic intervention will those therapeutic intervention fail, then we'll go for this bypass surgery, right? Small heart attacks should not be covered with the bypass surgeries. Small diseases, small infections should not be covered with high-fi antibiotics, right? So if you use the high-fi antibiotics for the small infections, you will develop resistance, right? That will experience, that similar theory, similar principles will apply to public health intervention as well. What we use in the hospital, it applies to public health interventions as well. So we are public health experts and we are working in the ground level. So we are using this intervention theoretically and scientifically. So those are the stages of pandemic and the strategies.
So thank you. So we'll go on to the next topic that we have. So what are the success stories of controlling COVID-19 at field level in Sri Lanka? And
Right.
Dr. Krishan, would you have any graphic to show?
Yes,
share
I
with
don't
us?
know whether it works here. I will put this one, and can you see the photo?
Randev, is it visible?
Actually,
Nothing is yet, doctor. If you could share screen.
Share screen, yes. Right. Can you see this photo?
Yes, visible. Yes.
Yes. So this is the photo was taken on the exact date was this photo was taken was 29th of March 2020. So this is one of the public health interventions we have implemented in China Fort, area called China Fort, Beruwala. You might remember that we experienced huge epidemic, huge hike of cases in the Beruwala area during the first wave. I remembered in March, April, right? So this is the area that we are collecting the people to sending out from the village. So we had a 1.5 square kilometer land area with a population of more than 15,000, right? There's a calculation formula that we make the scientific calculation to send and to take the decision. After that calculation, we take the decision. If that value of that scientific formula and calculation gives more than 500, we have to remove that people from the quarantining for institutional quarantine. So it's a bit scientific thing. I'm not going to explain that one. Anyhow, we did that calculation.
That's due to density of population, is it?
Density and the caseload, as well as the behaviors, right? Their behaviors, how they comply with our intervention, how they comply the PCR testing, other stuff. But these people are so much comply with our intervention at that time. So anyhow, so we calculate that one. It was more than 500 at that time. So we decided to remove 291 people from the area to some other place called Punani, right? So we put the institutional quarantine for 291 person. And most important thing is that at that time there were a huge epidemic in that area. We have to control it within 2 weeks. We need to control it within 2 weeks time. We used the method called double quarantining, first line and second line quarantining. So those days we were actually deficit with the PCR testing. We had only MRI Colombo, MR Borella supporting for PCR testing at that time. So it is very the hi-fi test we experienced during those days. So we use the public health intervention without going for PCR testing much, and we are not that much rely on this testing other than the practical intervention. So we quarantining 2 lines. Usually what we are quarantining after the positive COVID-19 cases, only first line contacts, right? Here we first line contacts and the second line contacts were removed, were sent out from the area to save the other people. So the total amount that we sent out at that time was 291, but the total population was 15,000.
So right? That is a double quarantine.
Yes, that is a double quarantine. Second line quarantine. Yes, okay. Double. It's a public health strategy. If you don't have the PCR facilities, if you have in delay in PCR reports to be come to your hand, so those instances you can use the double quarantine method, right? So this is the photo was taken when we were taking down the people from the houses and sending out to this institutional quarantine. So after that, we settle almost zero. After a few weeks time, we settle the epidemic in the Beruval area. So, but after sending them to the Punani institution, we were informed actually that there were hike in that particular place after doing the PCR testing in the institution in the Punani. So that means the cases were there, and after we have sent those, we had sent that people to that particular institution and detained them in that particular place. So there's the positive PCR patient in that institute, but we saved the other people, 15,000 people. Out of 15,000, 291 were sent out. So it's the one story that how we using the basic public health interventions without doing this hi-fi PCR and other stuff, managed the huge epidemic in Beruvala MOH area. So other than that, the second intervention, second example, second success story that I can remember when I was appointed as a ground level expert to control the naval base cluster, right? Naval base cluster in Valisara. So the Director General of Health Services of Ministry of Health appointed the expert committee to go and investigate on that cluster in the naval base Valisara. So I was one of the members appointed to go there, and I visited that place, and with the experts from the epidemiology unit as well as the regional director of health services area Gampaha. So I visited that place, and we gave some recommendation to the naval base when they were at the caseload of 850, I remember. So after that, it was settled. Another 100 was gone. Another 100 were gone, and after that it was settled at the 933 or 31. So anyhow, that was another success story that we use our public health intervention to control that one. Not only that, the previous example, very recent in the last week, we used another public health strategies and intervention to control the epidemic happened in the one of the faculties of University of Kalaniyan last week. So you might listen to the news at the TV or the media. It was telecasted day before yesterday or 1 week back, 2 days back, and we control it by only using this double quarantining and using the public health intervention, public health strategies without doing the PCR testing, because these days the PCR testing, to have the PCR testing is challenging, and to get down the PCR reports in time is a miracle, right? So you will get the PCR reports after 5 or 6 days time. So in that type of instances, you can't wait for a long time. Then after 7 days, the epidemic will be spread out to the whole university, right? Whole faculty, right? Whole university, because these days they are having the exams. So we can't wait for 7 days to have your reports on your hand, right? We have to use our public health interventions strategies, especially focused on the problems identified at the ground level. That should be practical, that should be scientific, and that should be imposed easily for that particular place. So we use that same strategy there, and we quarantine first line contacts and second line contacts in the hostels of the faculty. And now it has, to some extent, it has been settled. So those are some success stories I can remember. So that is right. Dr. Srimal.
So then we'll go on to the next topic we prepared: how factory epidemics were brought under control. How factory epidemics were brought under control, and what were the strategies used?
Right. So as all we know, this epidemic, so the second wave really came with the one factor.
Do you have any graphics to share with us?
Yes, I have some graphics. All right. So we experience. Can you see that one?
No, not visible.
Right. Now you can visible. Now you can see.
Doctor, if you could select one of the relevant photos.
Right.
Top right corner. No?
I will share with the time, right? I don't think it has been gone somewhere. Can you see that one? Still not, no?
Yes, doctor, that's visible. If you could just zoom in on it, and it will be enlarged.
Is it visible now?
Yeah, we can manage like that, doctor.
The statistical analysis of.
So is it visible now?
Next factor.
Now clear,
yes,
no?
It's visible.
Right. So yes. This is one of the factories, right? One of the factories which give the huge epidemic in the BOI region, Katnayaka. So you can see that we have analyzed their data, right? We have analyzed their data. We control the epidemic, and we have analyzed their data by using their sick registers, right? So this is the one of the most important documents that can be used to control and use as a surveillance purposes to control the COVID-19 epidemic in the factories, right? You can see the people, how we analyze. You can see the sick workers, non-sick workers, and after some time they did the PCR testing, and how much become positive among sick workers, and how many workers were become negative, positive among non-sick workers, right? There's a cohort analysis, what you call, then there's a significant difference, significant association with the sick register, with the epidemic of that particular factory, right? So you can see that the number called 4 here, right? You can see the number called 4 here, right? So that means right? So that means you can see, no? Did you see that one?
Yes, yes.
Right.
We saw the
So
calculation for
that mean that number 4 is there. That means the significant association with that number 4 for the sick people, sick workers in that factory. So number 4 mean we have analyzed the number of sick people who have reported to their sick rooms having cough, cold, and fever, which is more symptomatic and the more abide with the COVID-19, right? COVID-19 symptoms. So we analyze among 70 workers who reported during that time last week, within a week time, out of 70, 20 became positive with PCR done afterwards. So that significant association of 4 mean every fourth, after the fourth employee who complained about the cough, cold, and fever, fifth one became positive, right? Fifth one became positive with PCR testing. So we informed them, if it is possible them to after this cluster settle, we inform each and every factories after analyzing their own data, right? This is not something coming from other countries, or something coming from some other districts, right? Analyzing their own data, we highlighted them, and we highlighted them about the importance of maintaining the proper sick register and appointing a factory nurse for the factories if they are having a huge number of employees. So if they maintain the sick register, if it is possible, right? If it is possible, if we can inform the medical officer of health of the area after every cough and cold, fever, suspecting COVID-19, I don't think it is practical in the huge factory, right? The factory is having 3,000, 4,000 employees. It is not practical, right? So if they inform medical officer of health of the area, every fifth patient who complain about cough, cold, and fever, right, which is more suggestive towards COVID-19 in the Gampaha district, that might help us to control the epidemic in that particular factory in early stage, right, without going to 600, 700 cases per overnight, right? Per night we got to 700, 800 cases. So that means we are too late, right? At that time we were too late, but now we learn from those instances, those lessons, and we analyze the data and we presented to them to maintain the proper sick register. Other than the sick register, we ask them to appoint a focal point for every factory to coordinate with the district level and the medical officer of health level about COVID-19. So they appointed, sometimes some factories, they appointed the health HR managers, right, human resource managers, as a focal point for COVID-19. And in some factories, they appointed factory nurses as a focal point for COVID-19 coordination. So that is another strategy that we use to control COVID-19 at the early stage of epidemic in the factories. And the third thing that we have done for the factories was we conducted a series of lectures to acknowledge and be aware about the places, red zones, or the designated area with high prevalence of cases in Gampaha. So they knew in that area, if one person or one employee is coming from that area, they knew that they are in high risk. So they better stop them for a 1 week or 2 weeks time, not to come to the factory. So the fourth intervention we implemented in the factory was we asked them to streamline the transport method that they are using to transport employees from their boarding places to factory, right? Usually what they are doing is they were practicing was use the one particular staff service bus, and they get down employees from here and there, and those employees were transported to several factories. So we asked them to stop it and use the bus or staff service, only one bus for one particular factory, right? One bus for one particular factory. So that intervention really worked in the factories, and we control the epidemic without closing a single day of BOI Katunayaka. So we actually having 49,000 employees in the BOI Katunayaka, and we experienced many cases there. But anyhow, up to now we had small upcoming of cases, but it is manageable, right? It is manageable. We can manage so many the small epidemics in many factories, but because of this sick register and their alertness over this epidemic. So those are some, I can show some photos as well. You can see
Yes,
that we were there, and we were there in the can you see the photo?
yes, it's visible.
It is visible.
Yes.
Right. This is the one of the factories we visited. Right. We visited the factory and factory, and we find the index case. Right. I think you can understand what are the positive, what is the meaning of positive case, what are the meaning of index case. Right. So to find the index case, we personally and physically visited to a particular factory and find the actual source. Right. If you are not finding the actual source, or if you are not finding the index case, the epidemics cannot be controlled. Even with the sick registered, even with the other interventions, factories will experience the repeated positive patients in the factory if you are not identified, or if you are not supporting them to identify the source of infection, right? Sometimes they are having many sections in the factories, right? Sewing sections, cutting sections, and warehouse finishing sections, right? Sometimes the source was in the warehouse, sometimes the source was in the kitchen, right? In some factories the source was in the kitchen, right? If you are not competent enough to find the source of the infection, that kitchen will repeatedly give the infection to the whole factory, right? So it is actually necessary you to go there and have a meeting. You can see this photo as well, I think. So in the meeting, we get down all the HR managers, MDs, and we analyze their data, and we suspected, with the suspicious of some source of infection, we went to that particular place, and we asked them to we sometimes we question the people who are employees who are around that section, ended up with the finding the proper source of infection. So those are the intervention that we use to control the epidemics in the factory at the early stage.
Right. Thank you. So then we'll go on to the remaining topics. What are the new approaches for PCR testing and antigen testing?
Right. So this is one of the intervention that we use. You can see this photo, no?
Yes, visible. Yeah.
Can you see this photo, Dr. Srimal?
I can see it. Yes. What about you, Randev?
Right. Right. Is it visible, Randev?
Yes, you go ahead. Go ahead.
Right. You are visible, Dr. Srimal?
Yes.
Right. So this is one of the intervention that we have used to get the PCR done without using these PPEs, personal protective equipment. Then you might see that when taking the PCR sample, three or four people, the staff, health staff were on PPEs, right, to take the samples. So in this instance, so we use the mobile PCR unit, and that is a mobile PCR van actually. So for this one, we no PPEs. The person who is inside that particular van need not to have any PPE to take the sample. Only have to wear a mask, right? So only one person is necessary to wear a PPE to support him from the outside, And the most important thing is we are doing the PCR at their doorstep. So it is not like what we are experiencing, what we see in the communities, that we collected the people, the suspected people into one particular place and get the PCR done in that particular place. So here we are not collecting people to one particular place, but we went to that particular person's house and get the PCR done. So minimum movements of the suspicious infective people from here and there, and we get the thing done without exhausting our health staff, and without exhausting our what you call the resources, right?
Avoiding
so this
risk
is
also,
another
right?
vehicle that we,
And avoiding risk of
yes, this is,
exposure as well.
yes, avoiding the risk for the health staff. And this is another bus. This is a bus, that is a van. So van for the small roads, bus for the large roads, right? If you go for the slums and some small village roadsides, so you need to go using that particular small van, ambulance van. So this is the bus. So this can be used for the large roads. So it has 2 PCR sampling units in the both sides, so it is easy. And we are going to those steps of these people and get down the people and get the PCR done, right? This is one of the new methods that can be used without exhausting our health staff, without reducing our utility of resources, especially for the protective equipment, and take the accurate sample
And
with
avoiding
safety
exposure.
Yes, avoiding exposure to the health staff, minimizing the exposure among the public as well, because we are taking the sample at the doorstep. So those are the intervention that can be a new intervention, new approaches that can be used for PCR sampling, and it is practical, and it can be used very easily, and it can be trained to the people who are taking the sample, and it has been practically working now, physically working in the Gampaha district now. So these are interventions which has been planned by myself and trained the public health staff, now currently working in the Gampaha district.
So any brief word on antigen testing? Anything you can say about it?
Antigen testing, actually, what we are doing for antigen testing, the scientific rationale for doing antigen testing is, Dr. Srimal, it should be done only for areas or only among the communities which have high prevalence of disease, right? If you are suspecting low prevalence of disease among one community, so one district or one factories or among public, antigen testing should not be used, should not be implemented, should not be tested, right? If you are suspecting more than 10% prevalence, the positive predictive value, it is a bit scientific word that we are using for to indicate the what you call
possibility of finding a positive case, isn't it?
Yes, positive predictive value of the test, right? So it is the one method that we analyze whether the test is good or bad, right? There are methods that we can there are methods and strategies that we used to assess whether the particular test is good or bad, right? The one method is positive predictive values. So if you have a prevalence more than 10% in one particular community, you can have a 78% of positive predictive value by using the this test. So if you are suspecting more than 10%, right? Otherwise, no need of using the antigen testing like that in that particular community. So currently in Gampaha, we are using antigen testing only among the first contacts, and only among the high risk communities, right? In some communities, there we suspected some sort of high prevalence, right? They are also our Sri Lankan people. So we suspected some high prevalence, and in those instances, antigen tests can be used suspecting more than 10% of prevalence. So if you suspected more than 10%, the positive predictive value for that test will go up.
Excuse me, doctor.
Right.
Yes.
Okay. Yes, Randev.
Doctor, could you just off your share screen and continue with your talk, doctor, because the audience cannot see you.
All right.
Okay, that's perfect. You may continue.
Okay.
Right.
So then, thank
antigen
you.
testing, what I said is antigen testing that we have to use. The scientific and rational testing method to have a good outcome, good output from the testing strategies, because we are using the public money, we are using the public resources, we have a very finite resources, not only our country, not only in Sri Lanka, but everywhere we have very finite resources, right? So in that purpose, we have to use we have to use our resources rationally and scientifically.
Okay. So thank you, Dr. Krishan, for your insights and your ideas into the very practical aspects of COVID, especially in the Gampaha district. So now I will hand over to Randev. Since we have concluded all our topics, he can go ahead with the rest of the discussion.
Hello, am I audible?
Yes, Randev.
Okay. Doctors, I will just move on to the audience's questions. Actually, we have got quite a few of them. We have got about 15 to 20 of them. So we'll be only being able to manage about 5 questions at most.
Right.
So I'll try to combine as many questions as possible. Doctor, the first question would be, can you still get COVID after the vaccine, after you take the vaccine?
Yes, still possible, because we are giving the AstraZeneca vaccine these days for the health staff. So it only have 89 to 90%, 65 to 90%, 89, we say 90%. So 65 to 90% of efficacy. So even with the vaccine, what they tested for disease, the prevention of disease, not the infection, right? There are two difference meaning for the infection and the disease, right? You can get infected, but you will not get the disease. But if without getting infected, you will not get the disease, right? There are people who have been infected but not get the disease. There are people
asymptomatic
infected as well as having disease. So the trials they have done, stage 1, stage 2, and stage 3 trials were done for check whether there is any protection over the occurrence of disease, not the infection. So even with the data is very, very minimum, right? Even with the injection, there's a chance of getting infected, but there's a lower chance of getting to have a disease, right? Especially the complications, the mortal complications and the serious complications related to disease were assessed during the clinical trials. Those were very low among the people who have been vaccinated with the AstraZeneca vaccine that we are currently using in Sri Lanka. So my advice is, if you get the vaccine, better get vaccinated. You can get the infection, but still you are protective against the disease. You are protective against the serious complications like death, like pneumonia leading to the fibrosis of whole lung. So you are the patient for rest of your life. So those serious complications were tested, were assessed, were documented in all 3 stages of the trial. So those were documented, anyone can see. So it is protected over the serious complications as well as the disease.
So there's a clear advantage in using the vaccination. Yes, Randev.
That answers another question actually, because we have gotten many repeated questions saying how safe is the COVID vaccine, because they have been renowned for, there have been side effects that have been, There have been many thoughts on side effects that could occur when you consume the COVID vaccine. So that actually answers quite a few of it.
Right.
Is there any more to elaborate on it?
Yeah. Let me elaborate with the some other example of vaccines. Right. We have vaccinated very little children. Right. Year 2 months, 4 months, 6 months, 9 months, 1 year, 3 years. Right. Very small children with the vaccine with the live attenuated vaccine. Right. MMR, measles, mumps, rubella. That vaccine have live attenuated virus. Right. We vaccinated at the age of 9 months and at the age of 3 years. So those
Just
are
not
live.
everyone has been vaccinated with that.
Yes, live attenuated vaccines, right? So this vaccine was this vaccine is not a live attenuated vaccine. This is a recombinant vaccine. They used a small part of,
AstraZeneca.
yes, AstraZeneca vaccine, COVID-19 vaccine is a recombinant vaccine. It is not a live attenuated vaccine. The most dangerous some sort of dangerous seriousness can be there with the live attenuated vaccine, but it is very minimum, right? But we are using it for small children as well. So this is completely safe, right? We have vaccinated more than, in my district, we vaccinated more than 10,000 health staff, right? We were reported only mild fever, cough, back pains, and small vomitishness, right? Other than no serious complications were reported. Were reported in the Gampaha district. But you can have you might have some sort of sense, is there any possibility of interaction with some other vaccines if you have vaccinated for rabies, right? Sometimes anti-rabies vaccine were given to one particular person, and that person needs to be vaccinated with the COVID-19 as well. So if he needs to get vaccinated with the COVID-19, yes, it is safe for the people who have been vaccinated for rabies and get the vaccine during the time of vaccination of the rabies, because the rabies vaccination is going on from day 1 to day 6. 6 months to sometimes to 1 year. So during that period, if that COVID-19 vaccine is available, so that person is very safe to get the vaccination done. So it is very safe, I think.
I see. That's good to hear. I'll move into the last question, Doctor, because we are a bit short of time. Now, there has been a bit of a culture that has started with, having COVID around, where people are more into ordering food back home rather than going to the actual restaurant and eating. So they go to Uber Eats and stuff like that.
Yes.
But the question that I'm going to ask you, Doctor, is COVID-19 transmittable by food?
There are some evidences. Literature showed they are coming from fecal-oral transmission, but those are very limited literature that has not been used at the high level, right? High level mean there are some evidences. Researchers are there. They are fecal-oral route. Fecal-oral mean through the food, right? Through the food, it can be ingested and get infected. There are some literature, but to have some sort of solid evidences, we need to go for the literature called meta-analysis and systematic reviews, right? Those are a bit scientific stuff that we are using when we are taking a policy decisions, right? We are not relying on the one particular research or one particular literature or 10 or 20 literatures, right? We are relying on 10,000, sometimes 5,000 researchers and analyzing the data. So that after analyzing the massive data, that particular analysis called meta-analysis, right? And systematic reviews. So with these solid evidences, up to now, it has not been particularly revealed by WHO, World Health Organization. There is a possibility of transmission through the food, but we don't know. We don't know about the disease. The amount of knowledge that we are having about the disease is very, very minimum, very low, right? So up to now, what we are practicing is be on the safe side, right? Be on the safe side. If you don't know something, you better to be in the safe side rather than practicing that don't know stuff, don't know thing, right? Better to be in safe side. So that is why we are asking them to till we are getting the solid evidences about the fecal-oral route transmission, be in the safe side. That is why we scientifically ask for the cremations and not to share the things at the restaurants, not to share the meal at the working premises, right? In the working premises, they share the meal sometimes at the lunchtime. So those were discouraged to be in the safe side by the epidemiologist.
I see. Okay, that's brilliant. So on that note, I would have to conclude this webinar. So while on this concluding aspect, I would like to thank you, Doctor. I would like to thank Dr. Srimal and Dr. Krishan for sacrificing their time from their busy schedules. I'm pretty sure even though it was a Sunday, you all must have been extremely busy, because I can imagine that COVID-19 doesn't take a break for the weekend.
Yes, that's right.
I would also like to thank our partnering club, the Interact Club of Isipatana College, on their contribution and the efforts that they made to make this webinar a success. As well as I would like to also thank the doctors on sharing their insightful and their extremely knowledgeable facts and ideas on COVID-19 management and answering some of our audience's questions. On that note, I would like to conclude. So that's it from Quick Thoughts from QuickMed. Good night and have a pleasant week ahead.
Good night, Dr. Shiva. Good night, Randev.